Hello, everyone. I can't see you out there. I presume things are okay. The hosts can let me know if you can't hear or if there are problems. I will share my screen now so we can get going. I wanted to thank Monica Gao for organizing the events today, and thank you all for coming. I hope to share something useful with you, and look forward to sharing some thoughts. So my title is Living a Mentally Healthy Life with Narcolepsy. So at the end of the presentation today, you're going to be able to be optimistic about the future for narcolepsy. You'll describe some factors in narcolepsy that contribute to mental health and understand some management options and how to access them. So the first slide, be optimistic about the future for narcolepsy. What a time to be alive. We have greater access to information than we've ever had. Recognition of the condition is much higher. The delays in diagnosis and treatment are being reduced because people can figure this out faster than ever. It's still not perfect, but it's moving in the right direction. There's increasing alignment between psychiatry and neurology. So understanding the mental health implications of this condition are increasing. And the neurobiology of this is fascinating. Erection or hypocretin, the sick neuropeptide in narcolepsy, was discovered about 20 years ago and has revolutionized our understanding and treatment of this condition. And many new treatment options are now available, and more are coming. So this is a time to be optimistic. As a patient with narcolepsy, you're more than an orexin level. Your condition doesn't need to define you. What are your goals? Reach high. Narcolepsy should not stop you. And I think it's important to have an open and direct conversation with your doctor. What are your education goals, your work aspirations? Where do you want to live? What do you want to do in your life cycle? Do you want to have kids? So these are things that can be achieved and should be discussed, and we should target treatments to help get you there. So in terms of life cycle, there are some implications of narcolepsy. Some of the medications affect sexual performance. Some medications interfere with birth control. Medications may or may not be safe in pregnancy, and so that needs to be considered. For women that are breastfeeding, small amounts of medications can pass through the breast milk, so that is something to consider. You want to think about caring for a new child, not having cataplexy while holding an infant, for example. And then throughout life, what happens later? So as you get older and other medical conditions commingle and interact with narcolepsy and the medications. So these are the kinds of things we think about in an ARC over the course of care of a patient with narcolepsy, and are things that you should openly discuss with your doctor. So I'm just going to review one or two things you've heard before, you probably already know, but for some that don't, just a reminder about some basic features of narcolepsy. And we'll start with normal sleep, rapid eye movement sleep. And so the EEG, the brain waves, the electroencephalogram, is a bit slower than wakefulness, but it's a lot like wakefulness. You obviously have rapid eye movements, so that's defining for this state. And neurologically, quite interesting is that you're essentially paralyzed normally in REM sleep, and that contributes to some of the symptoms of this condition when things go awry. And of course, rapid eye movement sleep is associated with the dreaming state, so hallucinations, for example. And a lot of the problems in sleep neurology are when there are state control boundary issues. We spend most of our lives awake in non-REM sleep or REM sleep. But when we are somewhere in between, in the transition, a lot of the sleep disorders occur there. So I like to think of erection or hypocretin as psychic glue that helps stabilize state and keep people in one of these spheres of experience. Now, in narcolepsy, this goes off. And so we may see sleep enter wakefulness, so somewhere here, and that's excessive daytime sleepiness. We may lose motor control in wakefulness with an emotional trigger. That's cataplexy, and so that's in between REM and wake. You may wake up in the middle of the night and feel paralyzed, unable to control your arms or legs. And again, this is coming from REM sleep and still having the paralysis of REM entering wakefulness. So there. And REM at sleep onset. So normally it takes us about 90 minutes to get into REM sleep. And if we start into REM very early, we might have sleep onset hallucinations, which is another core feature of narcolepsy. So each of these symptoms can impact mental wellness. Chronic daytime sleepiness, which is essential in narcolepsy, is a progressive sleepiness, sometimes improved by brief sleep, and it may be associated with automatic behaviors, writing off the end of the page, driving past an exit, answering a question in class that you weren't asked. 2/3 of people have fallen asleep driving in the condition narcolepsy. So this is something that we have to avoid. So getting treatment to prevent this is essential. Obviously, this sleepiness has a big impact on quality of life. Feeling tired, run down, low energy. Well, that sounds like sleepiness, but it could also sound like depression. Cataplexy. 60% of people with narcolepsy develop cataplexy, narcolepsy type 1. And there's usually an emotional trigger. And one of the mental health implications is that some people selectively avoid emotional contact and withdraw. And I find this very sad and something that we really need to avoid. To limit socialization for this condition is a hard life decision. Falls can occur without injury generally, but people can injure themselves. And most of the cataplexy is short-lived, less than a minute. It's important to note this is an exaggeration kind of a normal response. Even patients without narcolepsy can get weak with laughter to some degree, but not to the degree you see in narcolepsy. Hypnagogic hallucinations, seeing people or animals, or sometimes auditory or even vestibular hallucinations. Vestibular is balance. Tactile, sense of touch, other people being in the room. We generally don't see olfactory or sense of smell hallucinations. That may suggest an epileptic basis, and it's a different pathway in the brain. Dreaming and short naps can be highly suggestive of narcolepsy. So these hypnagogic hallucinations can be quite profound and vivid and distressing, and sometimes can even be confused with a psychosis or schizophrenia. Sleep paralysis is where the voluntary muscles are unable to move. There's a preservation of breathing and eye movements, which are under a different control in the brain. This is particularly in the morning, and this can be quite frightening. It can be associated with anxiety. So there can be a sensation of fear or suffocation. So you see how these narcolepsy symptoms could contribute to potential psychiatric misdiagnoses or overlap. So daytime sleepiness, we talked about how that could be construed as depression, or maybe the alertness is impaired and it leads to attentional problems because you have to be awake to sustain attention. And so attention deficit disorder is sometimes mixed up. Cataplexy, loss of muscle tone with an emotional trigger, it sounds bizarre until you understand the neuroanatomy in the brain that makes it perfectly logical. But to many, this seems bizarre, and people may get labeled as conversion or hysteria or a functional neurologic disorder. Hallucinations, again, may be confused with psychosis or schizophrenia. So it's important to identify that narcolepsy is present as it's treatable. Sleep paralysis can occur and can be quite frightening and lead to anxiety. So those are some of the overlaps between this condition and some psychiatric labels. So I just wanted to discuss some of the data out there around associations between neuropsychiatric conditions and narcolepsy. And I won't get too technical, but I will summarize a couple things in the literature. I reviewed this just last week, and I was actually a bit surprised at how little there was out there. But there is some, and it's pretty clear. The prevalence of depression or depressive symptoms in patients with narcolepsy, a systematic review and meta-analysis. This was published in this journal, Neuropsychology Reviews, in 2021. And a meta-analysis is a study of studies. So they look at all the other published studies and extract information to come up with a consensus opinion about what all the other studies are saying. So this looked at 31 published studies. And they found that the prevalence of depression or symptoms of depression was about 1 in 3. So about 1 in 3 people with narcolepsy. In 13 studies that had controls, narcolepsy was about 3.5 times as likely associated with an increased risk of depression or symptoms. So using some age and sex matched controls. So comparing people with narcolepsy to those without, about 3.5 times the burden. This paper, Narcolepsy is Complicated by High Medical and Psychiatric Comorbidities, a comparison with the general population, in 2013 in the journal Sleep Medicine, looked at 320 people, and they interviewed them regarding their sleep habits, health, medications, medical conditions, sleep disorders, and mental disorders. And then they found control-matched population by age, sex, body mass index, as a comparison group. And what they found there was that the most frequent psychiatric disorders among the narcolepsy group were major depressive disorder, which was 2.7 times as likely. This is an odds ratio, which compares the group that has it to the group that doesn't. So about 2.67 times as much major depressive disorder and 2.43 times as much anxiety, social anxiety disorder. And overall, that affected about 20% of the patients. So a little lower than the other study, which looked at about a third. But some of these studies use very different definitions of depression. So in conclusion, this study showed that there was a high comorbidity of psychiatric disorders that need to be addressed when developing a treatment plan. That is, there's narcolepsy, but there's other things going on. The comorbidities, the associated conditions, have to be considered. This study, Sleep Disorders and the Risk of Incident Depression, a population case control study, was published in this Twin Research Human Genetics Journal, 2019. And they looked at a Danish population-based registry, a large sample, 65,739 people that had first onset of depression between 1995 and 2013. And they found an increased incidence of depression for all sleep disorders. So it's not just narcolepsy, but sleep disorders in general. And so the incident rate ratio compares how likely they are to develop the condition. And the highest association was for the sleep disorder of circadian rhythm disruption. So that was about 7-fold increased, and actually lowest for narcolepsy amongst the sleep disorders that they looked at. So sleep disorders in general need to be addressed to look for emerging mood problems. And so the results of this study suggest that having any sleep disorder is a risk for depression. It's just that narcolepsy is a clear contributor to this condition. When they looked in a community sample of narcolepsy in 2018 in the journal Sleep Medicine, Dr. Cohen looked at comorbidities in over 14 years, 2000 to 2014, in a community sample in Olmsted County, Minnesota, and compared this to controls. And what they found was that there was an increased association of narcolepsy with anxiety right at diagnosis. So at initial presentation, anxiety was about 4.5 times higher, and depression was about 4.88 times higher. But the interesting thing is, over time, so if they followed them for about 10 years, it drops. And so either the condition, the depression's being identified and treated, or the narcolepsy treatment has helped. And so this tends to get better over time. The conclusion here is that management of narcolepsy requires monitoring for and managing important associated health conditions. This study I've put in indulgently because I'm a co-author, and Dr. Narang led this study, who you're going to hear from later. And she looked at a population of adolescents and looked at depressive symptoms, sleep patterns, and physical activity in adolescents with narcolepsy. And we published this in the journal Sleep in 2019. And we looked at the association between depressive symptoms, sleepiness, using the Epworth Sleepiness Scale, and physical activity. And we assessed neuropsychiatric outcomes with a children's depression inventory scale. We looked at sleep quality with the Pittsburgh Sleep Quality Index. We looked at sleepiness with the Epworth Sleepiness Scale. And there was a measure of activity, physical activity, the Godin Leisure Time Exercise Questionnaire. And so we looked at 30 adolescents with a mean age of 14. And what we found was that there was about a quarter of patients had elevated depression scores, fitting with some of the prior studies we talked about at diagnosis, associated with poor sleep and physical activity. And we noted that adolescents with narcolepsy reported experiencing depressive symptoms associated with poor sleep, daytime sleepiness, and low physical activity levels. The implication here is that we might be able to improve sleepiness, and physical activity, and then thereby reduce some of the psychiatric depressive burden. So it's important to understand some of the management options for your condition and how to access them. Many of the sleep-wake neurotransmitters in the brain that control mood also control alertness. So that there are centers in the middle of the brain called the projecting systems that project wake-promoting transmitters to the brain that also influence mood. Stimulants, or wake-promoting agents, are sometimes used as mood adjuncts. So addressing sleepiness can help boost mood for sure. Some stimulants, however, can go too far and aggravate anxiety. So sometimes we have to dial it back or find alternative wake-promoting drugs. Reducing REM sleep can help improve mood and reduce REM-related symptoms. So a hallmark of narcolepsy is rapid onset REM. Hallmark of depression is early REM as well. And all the treatments for depression, talking therapy, drugs, push REM sleep later. And so we often use REM-suppressing drugs like antidepressants to help improve mood and to suppress some of the narcolepsy symptoms like cataplexy. We have many medication options. So the good news is we have many different neurotransmitter systems. We have many different antidepressants. We have many different new agents for narcolepsy to modulate these circuits. So if something doesn't work, then we will try something else. Control of symptoms can help. And so I think getting the narcolepsy under control is an important thing to do, but sometimes the mood disorder goes beyond that. So if there's separate depression, tearfulness, then pursuing talk therapy or medication therapy for those conditions can be helpful. And it's important to find support groups. Patients can find great help in identifying others who have the condition, support from family, support from medical professionals, psychologists. Pursuing talk therapy can be helpful as well. And I'm always reminded of this quote from the Journal of the American Medical Association. I think it was in the 1920s. Dr. Francis Peabody said, "One of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient." So it's not just about the erection level. It's about helping you get on track in your life and reaching for your goals and aspirations. And so I encourage in my clinical practice an ongoing dialogue about life plans and priorities. And we try and help get people there. People want to be musicians, they can do that. If they want to teach, if they want to have a baby, if they want to be a firefighter, like we work to get to where people want to go. So I have some sleep and mood advice that's applicable to all. And one of the things that we sometimes see in the clinic is kind of defeatism about medical condition, having narcolepsy and then not trying, and that doesn't cut it. So everybody has to pursue good quality sleep. And so we have to ensure all associated sleep disorders addressed. And so one of these things is just simply ensuring adequate sleep time. So making sure people have enough time to sleep. If you have narcolepsy, you still need to kind of aim for 8 hours of sleep, however you get it. It's important to stay active. So change in posture, standing up increases alertness. Just moving around and staying healthy is helpful. Getting light in the day is important. So the natural circadian rhythm, we've had organisms evolve over millions of years to reach for the sun and then have quiet periods. And we need to do that too. So, get outside in the morning, get bright light exposure. Avoid problematic substances. So in particular, marijuana is just really problematic in narcolepsy. It accumulates and people get sleepy and tired. And so this is an issue for many. Build supports and find like-minded people you can talk to, and friends. And I just wanted to remind everyone that this has been a hard time for many. The last couple of years have had, huge impact in our society, and a lot of people are going through a lot of stuff. Unfortunately, people with narcolepsy have an extra burden, but in some ways, there is some benefit of the current situation. I've had many patients where they've been working more at home and having to commute less, gives them extra time to sleep, allows them to take a nap. So there are pluses and minuses to what we've been through. So in conclusion, you're more than an erection level, and figure out what you want to do and do it. There's an association between narcolepsy and psychiatric symptoms. Get help if you're in trouble. Treat the symptoms of narcolepsy and separate psychiatric problems. Look at behavioral management, medications where appropriate, and better medications that are now available and more that are coming. And be optimistic, because I think we're at an exciting time in management of this condition, and things are improving. So that's my presentation. I wanted to thank you very much. I can't see out there in the ether, but I hope it was useful to someone. So be happy to take questions at this point.
Yep. Dr. Murray, thank you. Excellent presentation. You do have a few questions in here. Let's see. Dr. Murray, first, great suit. Somebody commented on that. And second, do you have a recommended response for when people that don't understand narcolepsy suggest that everyone is tired.
Yeah, it's an order of magnitude different. And I think, I think the profound sleepiness that people with narcolepsy have is underestimated. And I think there is a general lack of awareness in the community about the impact of sleepiness. I think organizations like this are raising awareness, and I think spreading the word is important. I think you can tell people this isn't just sleepiness. It's not a voluntary thing. Like diabetes, not having insulin is beyond your control. Not having erection signaling influences alertness greatly. I think it's pretty hard to convey that information, but I think letting them know it's a medical condition of profound sleepiness in the brain. It's a brain disorder is important to message, and letting people know. I guess the most comparable thing in kind of everyday experience might be newborn parents who are sleep deprived in the care of a newborn, being up frequently with a baby. That's probably about the closest experience that most people could possibly relate to. Or you could maybe say, imagine how you feel after a full night of sleep deprivation, staying up all night, pulling an all-nighter. How do you feel? I mean, that's how I feel every day. And I think that kind of message might be a way to signal some understanding.
Excellent. Thank you, Dr. Murray. Another question from this person about remission in type 2 narcolepsy and how you counsel patients that experience it. This person was diagnosed with type 2 narcolepsy following H1N1, but saw symptoms go into full remission in 2016. His doctors at Trillium, West Toronto, were helpful in helping him transition back to normalcy, getting his license back while no longer medicated, but they had little to say about the long-term trajectory of remission. Does it come back, etc.? Are there any resources you can recommend on living with remission?
Yeah, I think everybody's unique in that regard. I have seen patients that wax and wane in their symptoms. So in general, I keep most of my patients with narcolepsy on a 6-month follow-up schedule unless they're absolutely stable, because things change over time, and things change not only with narcolepsy, but in your life. People end up on new medications, they develop sleep disorders, they have mood problems, or they have kids, or they retire, or all sorts of life events influence the condition. So I think that's a factor. And certainly narcolepsy fluctuates some over time. There are periods of time where people are more troubled by, cataplexy, and other times where it's not so bad. And so some of this is kind of unpredictable. Season probably affects things as well. Aging definitely affects things. In terms of other conditions, another situation, not narcolepsy type 2 per se, but idiopathic hypersomnia. I've had a number of patients where they've had inflammatory medical conditions, things like psoriasis or inflammatory bowel disease. Once they get that treated, the inflammation goes down and alertness improves. So there is an interaction there for sure. So I think it's pretty hard to say in an individual patient. There could be so many factors, but definitely things can wax and wane, and generally fairly stable. But some have some fluctuations for sure. I think that's about as best I can answer.
Thank you. Just on that note of remission, is it common for somebody with narcolepsy type 2 to go into remission? And is it impossible for somebody with narcolepsy type 1? since they've lost their erection?
I would say it's much less likely for remission in narcolepsy type 1. In narcolepsy type 2, there may be issues in a diagnosis. Maybe the diagnosis is not exactly correct. It can be a little harder. And so sometimes, it may actually reflect, an inflammatory condition, a idiopathic hypersomnia state. So it is not common for remission in general, but it can occur. And I can't say I've seen many people with type 1 have spontaneous remission, but some have been able to manage better in their lives and not need medications at certain times. But it depends on the scenario, and it depends on the severity at an initial presentation. For many with profound sleepiness and cataplexy at onset, it is a lifelong situation.
Okay, thank you for clarifying that. Another question. Thank you for the great presentation. Do most patients have orexin levels measured as part of their diagnostic criteria?
Yeah, so it's a bit different in Canada. The U.S. Often obtain orexin levels in diagnosis. I would say in Canada, we don't have a standardized laboratory for assessment of orexin levels. In rare cases, we can send it to the U.S. for measurement, but this assay is a little tricky to set up, and the volume of Canadian patients is less, so it's not as frequently obtained. I seldom obtain it in my clinical work. If the diagnosis is clear, confirmed by neurophysiology MSLT testing, or the story is very clear, then oftentimes we don't need it. And even if the level is the level is not always abnormal, and so we have to depend a little bit more on patients' symptoms for management long term. So I'd say in Canada we very rarely check the orexin level.
Okay, thank you. Regarding depression, would you be able to talk about when warning signs for depression are more than just narcolepsy and should be treated? How would people identify, like self-identify, if it's a point where they need to seek treatment?
Yeah, this is a hard kind of distinction, because a lot of the symptoms of sleepiness and mood disorders can overlap. Just feeling tired, run down, low energy, like that sounds like depression. It sounds like sleepiness. So I would say in narcolepsy, we want to ensure, first of all, that all the sleepiness that has been around is addressed. So we try and get people as awake as possible before moving on to another diagnosis. The simplest diagnosis is always one diagnosis rather than making multiple diagnoses. So we try and get people awake as best possible. Similarly, we'll have people with, they'll come and they'll say, I have a memory problem. And they really don't have a memory problem. They have an attention problem, which makes it hard for them to form a memory. So getting people awake can improve cognitive function. So I always try and get the alertness managed as best possible first. And then after that, if there's persistent symptoms, then considering talk therapy or medications specifically for depression might be considered. Sometimes we use medications for the treatment of cataplexy that also help mood. So an antidepressant can sometimes help both. So that's a scenario we're often in. As a rule of thumb, kind of a gut feeling, I think when people become tearful, then it's more than just sleepiness. So that to me becomes a point where I'm more concerned about a separate mood disorder. And if there are thoughts of self-harm or severe depressive symptoms, not engaging in society, then that's urgent, and that needs to be addressed by most likely a psychiatrist in an urgent manner. So those are some kind of milestones where I just think we have to be looking at it a bit more aggressively for addressing a mood problem.
Okay, thank you. If somebody is at that point, or even not at that point, but at a point where they do want to talk therapy to a therapist, do you recommend that they try to seek out a behavioral sleep therapist? Or do they, somebody who specializes in narcolepsy, and how hard is that to find somebody?
Yeah. I think a behavioral sleep medicine specialist would have the understanding and skills to help navigate that space. But oftentimes, we've identified there's a separate mood problem, and then that's where I'm engaging a psychiatrist with, for mood problems specifically. But I think any mental health professional with experience in mood disorders is going to be able to help navigate to the right place. And I think the most important thing is identifying it and getting there. And so so moving the ball forward rather than languishing.
Okay, great. Thank you. Somebody else is asking, do most of the new medications have severe side effects? You mentioned some stimulants actually create anxiety, and I've read some accounts of scary side effects, such as feelings of rage with some of the newer meds. I suspect the benefits outweigh the side effects, but it's still worrisome as a parent of a person with narcolepsy.
Yeah, I think a lot of the labels on psychiatric medications are as a parent would be off-putting, scary for anybody to read. But most of the time, these medications have been studied in large populations and are pretty darn safe. And if the option is presented by a sleep clinician, there's usually a good reason. Like, I don't want anybody on medications that don't need to be on it. But if you're not awake, you're not going to do well in school. You're not going to thrive, and you're not going to be able to reach your educational goal or your work goal or drive or whatever. So I think, there's some reluctance around medications, but they're there for a reason. And I think at some point you have to trust your clinician, that they're acting in the best interest. There's no other agenda here. My only agenda in treating patients with narcolepsy is to help get them on their path. And so I think don't be off put by one-off descriptions in these labels. Talk to the doctor. How likely or frequent is this? Rare. Most of the time, people do really well. So things can be balanced, right? Like, you can adjust the dose. If the stimulant's too much anxiety, well, we have to back down. And everything in medicine is a balance between risk and benefit. So we increase dose to get effect, and we reduce dose to avoid side effect. And the sweet spot is not determined by your doctor. That's what I like, or what I can handle, or what's getting me where I need to go. And that's a dialogue you have with your doctor to help find the right spot.
Great, thank you. With the life cycle of perimenopause and aging in general, noting the importance of sleep for the general public, what can a person with narcolepsy type 1 expect regarding cognitive functioning if sleep is already a problem? Any insights to help through the transition along with narcolepsy?
Yeah, menopause in and of itself is associated with change in sleep symptoms. And so addressing that as best possible can help improve experience with narcolepsy. So I've had a number of patients kind of in this situation who have identified other sleep disorders. And when we address that, then things improve. And I think just addressing comorbid conditions is essential. So in particular, sleep disordered breathing goes way up in postmenopause. There are hormonal influences in respiratory centers in the brain, and and influences greatly sleep quality. So that is definitely something to consider. So not just kind of focusing on narcolepsy, but saying, okay, well, there's narcolepsy. Could there be something else now new that's going on that's contributing, and getting that addressed to optimize function.
Okay, thank you. For me personally, I have had great success trusting my care team, which includes my family doctor, my neurologist, and my talk therapist. They are not specifically sleep trained, but have always provided what I need. How important do you consider a well-rounded care team?
Yeah, I think it is great that you have landed on a good solution, because all that matters is how you do. Doesn't matter what kind of doctor it is or what labels they've got. If you're on your path and you're doing okay, that's the right group for you. And I'm very happy that you've been able to find that. A lot of people haven't, and so I think it's finding the right people on your team and can advocate for you is what's important.
Excellent. Thank you, Dr. Murray. I think that's the last question we had. So I think we will thank you very much for your presentation and your time. And if you're joining us for the rest of the webinar, feel free to stay on, and we'll bring on our next presenter.